So, good afternoon again to everybody. After months of fantastic conference, we have indeed enjoyed, all projected towards the future. Perry and Alexandros and Max offer us a jump back more than a century, providing us the possibility of speaking about standard electrocardiogram. And this indeed is the title of my talk. I'm very happy in any case to accept their proposal, since I really love electrocardiogram. Anyway, I will do my best to show that the most appropriate title of my conference would probably be, quoting Robert Zemeckis, Back to the Future. In fact, the electrocardiogram is experiencing a real renaissance, and this is due to the current availability of large databases of patients with detailed, definite image, histologic, and genetic diagnosis, the availability of systematic studies on genotype family members, the non-invasive characterization of myocardial substrate with MRI, and the availability of large outcome studies. So the main points of my speech, the main points I would like to discuss with you are at least four. The first one is probably the most important, and is the need for a cardiomyopathy-oriented mindset while interpreting the electrocardiogram in a subject with definite or possible cardiomyopathy. The other points of the agenda will be the electrocardiogram as source of diagnostic red flags, the electrocardiogram as a tool to define the phase of natural history of the disease and the prognosis of the patients, and possibly the electrocardiogram as a source of genotype and phenotype correlation. Let me explain. In a patient with hypertensive heart disease, hypertensive left ventricular hypertrophy, it's clear that the increase of the anatomical mass that can be captured from the echocardiogram is indeed the source of everything, and the consequence of this increased anatomical mass is the development, as you can see, of a classic picture of left ventricular hypertrophy. So it's clear that the mother is the increased left ventricular anatomical mass, and the daughter is the electrocardiographic left ventricular hypertrophy. This is not the same in the field of cardiomyopathy. Let's consider, for example, a family screening. This is an old but very important paper published by Celia Oakley more than 25, 30 years ago. And we perfectly know that electrocardiographic patterns of left ventricular hypertrophy can appear before the appearance of left ventricular hypertrophy on echocardiogram. Also, screening athlete, this is a famous paper by our colleagues working with the CONI, so top-ranked athletes in Rome, in Italy. In these three cases, for example, these absolutely abnormal electrocardiograms, suggesting at least the presence of hypertrophic cardiomyopathy, coexist with normal echocardiogram at first observation. And in hypertrophic cardiomyopathy phenotype, in these cases, developed only after 12 years of follow-up. So very different situation. Another observation that is quite interesting. The slide is due to the courtesy of Jacopo Olivotto and refers to a patient with obstructive cardiomyopathy. This is the baseline electrocardiogram. If we treat, and he indeed treated these patients with mavacamten, you know that perfectly that mavacamten is a new fantastic drug aimed to the decrease of the gradient, but indeed it's not a hemodynamic drug. It's a drug directed toward a specific biochemical target, that is the protein. And here you can see this strange effect of mavacamten on the actomyosin bridge. So a more sophisticated and biochemical target than the simple hemodynamic target. In this case, after 6 weeks of treatment, this is the result. The electrocardiogram indeed is ameliorated or normal, as you can see, while the anatomical mass is just the same or with minor differences. So what has happened? It happened that treating a specific biochemical intracellular target, in this case at least, we can obtain a dramatic change of the electrocardiogram. So we need to consider another model, not only the model mother and daughter, but we have to consider the possibility specific to cardiomyopathy that there is a common mother, the protein abnormality, that cause at the same time, also in some cases in different moments of the life, an increased left ventricular mass and left ventricular electrocardiographic hypertrophy. So electrocardiographic left ventricular hypertrophy and increased left ventricular mass in these cases are sisters. Other point that bring us to the necessity of developing a specific cardiomyopathy-oriented mindset while interpreting the electrocardiogram. Classically, we speak about necrosis, injury, and ischemia, observing Q waves, ST shift, and negative T waves. And classically, somebody taught us that these are the results of a real scar, of an ongoing ischemia, and an ongoing damage of the surrounding tissue. But can we interpret the electrocardiogram of our patient with cardiomyopathy with this intellectual framework in mind? No. For example, how can we interpret the abnormal Q waves that are typical of many patients with hypertrophic cardiomyopathy? In many cases, these abnormal Q waves are simply the result of the abnormal topography of intraventricular hypertrophy, with unbalanced of interventriculars and of free wall hypertrophy. But in other cases, with a scar evolution, probably due to ischemia, a classic Q waves appear in the natural history. Again, how can we interpret this electrocardiographic pattern of previous anterior myocardial infarction in the patients with amyloidotic cardiomyopathy? This is the heart, the explanted heart of the patient. And here you can see that the substrate for this electrocardiographic pattern of previous myocardial infarction is the scar-like infiltration of interventricular septum. So once again, a different mechanism. How can we interpret this deep negative giant T wave inversion in those patients with an obvious apical hypertrophic cardiomyopathy? Is this really a metabolic ischemia? No. This is the result of a specific topographic distribution of hypertrophy to the apex. And this is an important concept. The topography, I mean the intraventricular distribution of left ventricular hypertrophy, is the base to interpret, for example, negative T wave, in this case of arrhythmogenic right ventricular dysplasia. This negative T waves are the expression of a right ventricle that is captured by the leads. In this case, this is the case of left main arrhythmogenic left ventricular cardiomyopathy. These negative T waves in lateral leads, in inferior leads, are the expression of this peculiar distribution of the fibrotic infiltration, in this case of left ventricular arrhythmogenic cardiomyopathy. So, dear colleagues, we have to change partially our mind. This is the old concept we had in our mind. QRS, P-wave, T-wave abnormalities are produced by increased left ventricular thickness, cellular hypertrophy, scar, subendocardial perfusion abnormalities, conduction delay, and so on. This is true, of course, but we need another conceptual model. And this model is the current model. We have to explain QRS abnormalities also as the result of the direct effects of mutated protein on myocardium and on conduction system. We have to interpret both Q waves and ST abnormalities as a result of interstitial expansion and fibrosis of the myocardium. We have to interpret T morphology as the result of the specific topography of the myopathic process. One other comment: in the last, I would say, 10 years, new electrocardiographic waves have been clearly demonstrated. Epsilon waves, Brugada pattern, and fragmented QRS. So our mindset must change. We cannot base our interpretation of the electrocardiogram in a patient with definite or suspected cardiomyopathy with the same rules we used 30 or 40 or 20 years ago to interpret ischemic heart disease or valvular heart disease. Another important point: 12 leads electrocardiogram can be a source of diagnostic red flags for the differential diagnosis. This is a 45-year-old patient, and this is the electrocardiogram showing left ventricular hypertrophy, abnormal T waves, right bundle branch block. Can we use this electrocardiographic phenotype to orient our differential diagnosis towards something different from classic sarcomeric hypertrophic cardiomyopathy? Probably yes. Indeed, those patients had an Anderson-Fabry disease. Electrocardiogram is particularly useful in fostering the suspicion of Anderson-Fabry disease in a patient with a hypertrophic phenotype. Please note, please consider lateral leads. In lateral leads, the voltage is in general higher in patients with Anderson-Fabry disease. Please note inferior leads. In inferior leads, in a patient with Anderson-Fabry, abnormal Q waves are generally absent, whereas T waves are negative. And in the other most important point is that a right bundle branch block is very frequent in Anderson-Fabry disease. It is also frequent a shortened PR interval. Recently, in a paper involving some of the colleagues present at the Today conference, we tried to derive a score, an electrocardiographic, very simple score, taking into consideration PR interval, QRS duration, presence of right bundle branch block, amplitude of R wave in AVL, and inferior ST segment depression. It's just an example. I don't want to go into the details, but a simple analysis of these simple details can offer a tool for a differential diagnosis, or at least a tool for fostering the suspicion of Anderson-Fabry disease. It's not well understood why in Anderson-Fabry disease, in the initial phases of the natural history, PR is shortened, whereas in the end-stage phase, in general, AV block can be present. So a sort of biphasic action of the storage on the yeast bundle tissue. Nevertheless, another point, another classical situation where we can use electrocardiogram as a red flag is the diagnosis of amyloidotic cardiomyopathy. At your left, a classic echo and electrocardiogram of a patient with sarcomeric hypertrophic cardiomyopathy. On your right, the same echocardiographic picture, but a quite different electrocardiogram with tendency toward low QRS voltage. And this is the classic electrocardiogram that we usually have in our mind when speaking about amyloidotic cardiomyopathy. But, dear colleagues, please note that it's not the general rule, it's not constant. For example, these are cases with ATTR-related cardiomyopathies. In these two cases, a mild hypertrophy can be diagnosed, or left bundle branch block. If we compare AL amyloidosis with TTR-related, wild type and variant amyloidosis, we can see that the prevalence of low QRS voltage is high only among AL patients and not among TTR-related patients. So a real paradigm shift must be perceived. And the shift is from the search of low QRS voltage to the analysis of the relationship between QRS voltage and left ventricular mass. In this disease, the QRS voltage can be normal or only mildly increased, coexistently with the large increase of left ventricular mass. In clinical practice, we have also some magic number we can use from the consideration of peripheral QRS score and left ventricular mass, but this is not the point. The point is a cultural point. This paradigm shift from low QRS voltage to the relationship between QRS voltage and left ventricular mass. Entering into the field of classic electrocardiograms of patients with hypertrophic cardiomyopathy, the sort of collage tell us that there is a large heterogeneity in the electrocardiogram of classic sarcomeric hypertrophic cardiomyopathy. Left ventricular hypertrophy is definitely the most prevalent feature, but please consider that in some cases also this sort of right ventricular hypertrophy. Please note the ratio between R and SY in V1. So also right ventricular hypertrophy can be present. These Q waves in inferior leads associated with positive T waves, the so-called QT discordance, is a typical finding in hypertrophic cardiomyopathy. Another typical finding is the presence of giant T wave inversion. Another finding is the presence of STT abnormalities in cases with apical involvement of the disease. In other cases, please note there are abnormally high T waves. So not only giant T wave inversion, but giant T positivity. In other cases, the PR is shortened with pre-excitation patterns, and in these cases, we have to consider not only the presence of Anderson-Fabry disease, but more frequently of Danon disease, for example. And in no more than 4-6%, the electrocardiogram can be normal in patients with a definite diagnosis of hypertrophic cardiomyopathy. In our service, for example, the prevalence of these electrocardiographic details is what you can see. Please note this Q wave with QT discordance in 1 out of 4 patients. And please note the bottom line, ST abnormally elevated with giant positive T waves in 16% of the patients. These are, for example, 2 patients with this very funny appearance of STT. Imagine these patients referred to an emergency department for an atypical chest pain. Of course, the first diagnosis from the physician at the emergency department could be acute coronary syndrome. And indeed, this is a collage of patients from our series, a sort of ST myocardial infarction mimicking profile can be present. We try to analyze the prognostic implication of this. As you know, it's very difficult to use electrocardiogram as a prognostic tool in this disease. And previous studies using the electrocardiogram from a quantitative point of view produced very unpleasant results. If we use the pseudo-ST myocardial elevation pattern as a prognostic pattern, we were able to identify some prognostic significance. Another prognostic implication is related to the QRS duration more than 120 milliseconds. So left bundle branch block is the bad ominous sign in the disease. And indeed, at least 2 studies in the literature document this negative prognostic implication. We try, in a small subset of cases, no more than 1,000 cases, to combine the classic risk factors that in the working group of the European Society we identified some years ago using the parameters you know. We try to combine these classic risk factors with these relatively new electrocardiographic risk factors. I mean QRS duration, ST segment elevation, and positive T waves, obtaining some relatively promising result. And indeed, the ability of stratifying the prognosis seems to be higher if we use the electrocardiogram. This could, for example, be a starting point for an enlarged prospective study using the ECG as a prognostic tool. Unfortunately, recent studies tell us that among pediatric subjects with hypertrophic cardiomyopathy, the electrocardiographic abnormalities are often very dramatic. Nevertheless, the prognostic content of the electrocardiogram seems to be absent, at least in the study that involved many of the colleagues that today are present. In this disease, the electrocardiogram is also useful to monitor the natural history of hypertrophic cardiomyopathy. This is a classical example of end-stage evolution of this disease. We know that the histological substrate for this evolution is the appearance of fibrosis, is a scar-like fibrosis, just in this case, probably due to disease of the microcoronary circulation. So it looks an ischemia consequence. We have to distinguish this scar-like fibrosis between the diffuse intramyocardial fibrosis that characterize all the phases of the disease. Please note the difference between these two specimens. The first specimen obtained during the myectomy, and the other specimen obtained in an explanted heart. In an explanted heart, the total amount of fibrosis can reach 37–40%. Electrocardiogram typically in these patients evolving toward the end-stage phase show the appearance of low QRS voltage, and this is a classical warning for a clinician that is following the patients. Somebody developed the strange sign of the arrow. If you put the precordial leads in this way and you join the apex of the R and S waves, you can obtain a sort of arrow. But this is a joke, of course. The last point of my presentation, 5 more minutes, dilated cardiomyopathy. very rapidly some concept. The first concept is that dilated cardiomyopathy, as you know, is not a single disease. It's a sort of syndrome with many genes, many pathophysiological mechanisms involved in the production of this phenotype. So the key word is heterogeneity. Heterogeneity is the key word not only at genetic level, but also at electrocardiographic level. And indeed, many electrocardiographic patterns can be observed in this situation. The situation is different from hypertrophic cardiomyopathy. For example, here I would not speak about red flag, about phenocopies. And dilated cardiomyopathy is not the kingdom of phenocopies, since there is nothing to copy. The original is missing. What is the original situation in dilated cardiomyopathy? So, very briefly, some concept. The concept is that you can observe very frequent, most frequent electrocardiographic patterns, for example, left ventricular hypertrophy, left bundle branch block. But in other cases, we can observe low QRS voltage, abnormal Q waves, strange electrocardiographic situation. The presence of a huge left ventricular hypertrophy is very rare, since dilatation of the ventricle produced damage to the conduction system, and very frequently left bundle branch block appears. Many types of bundle branch block. Very rarely a classic truncular left bundle branch block, and more frequently peripheral types of left bundle branch block. Probably the distinction between truncular and peripheral level of the block could be important to select patients to electrical resynchronization. But unfortunately, our criteria are currently based only morphologic image and not electrocardiographic image. This could be another source of polycentric research. But there are, in some cases, some electrocardiographic hints able to foster the suspicion of a specific genetic basis. For example, in this case, a funny appearance of inferior, posterior, and lateral infarction is present. And this is relatively classic of dystrophy. This is a case of Becker dystrophy. So, posterolateral infarction as a marker of suspicion of dystrophy. In this case, for example, diffuse low QRS voltage. Please note that the voltage is low only for QRS, not for the P or T. So it's not a matter of in pericardial effusion, for example, cannot be the cause. It's something intrinsic to the myocardium. And this appearance, this finding, is quite specific of cases of phospholamban gene mutation leading to dilated cardiomyopathy. This is a very important recently published paper that tell us that low QRS voltage, negative T waves, and increased QRS duration can be used to construct a sort of prognostic score in this disease. So once again, the possibility of using the electrocardiogram as a source of prognostic stratification. Other examples, for example, in cases associated with lamin mutation, abnormal atrioventricular conduction frequently coexist. So, just to summarize, another example. This is a very funny electrocardiogram, low QRS voltage, very strange right bundle branch block with funny associated waves. What is that? Let's look at the detail. This type of electrocardiogram belongs to a sort of syndrome. Please consider these 8 cases, V1, AVF, V1, V2, V6. Very similar Again, low QRS voltage also in the lateral leads, and very funny right bundle branch block. This type of electrocardiogram can be produced in nature only by biventricular arrhythmogenic cardiomyopathy, involving both right and left ventricle. So a very, very useful electrocardiographic sign. What about a terrible situation that is left ventricular arrhythmogenic cardiomyopathy? This is a subtle diagnosis to be obtained, and we are not yet able to clearly diagnose in our real life this disease. Just an example, family history of sudden death. In these cases, the anatomic demonstration of left ventricular arrhythmogenic cardiomyopathy with fibrofatty dysplasia. Typically, the electrocardiogram of the patients obtained 1 year before his death showing negative T waves in lateral and inferior leads. The other components of the family in these two cases showed the same electrocardiographic appearance: low QRS voltage, negative T waves in lateral and inferior leads, with a magnetic resonance demonstration of the disease. And appropriately, in my line, Padua colleagues use the electrocardiographic findings of low QRS voltage and negative T waves as minor but definite criteria for suspecting or diagnosis left ventricular arrhythmogenic cardiomyopathy in clinical life. So to summarize, this is an important concept in my mind. An accurate analysis of the electrocardiogram in the patients with an echocardiographic phenotype of dilated cardiomyopathy can foster the suspicion of specific genetic variants. And the points are low QRS voltage, left or right bundle branch block, negative T waves, again, presence of Q waves, lateral or inferior leads, AV blocks, supraventricular arrhythmias. And these signs can lead to the suspicion of the specific genetic variants. Two considerations, just to conclude. Many times I use the expression low QRS voltage. Low QRS voltage is as important as left ventricular hypertrophy. And in my mind, low QRS voltage is a syndrome. We can observe in the field of cardiomyopathy low QRS voltage, for example, in amyloidosis, in myocarditis, in right or left arrhythmogenic cardiomyopathy, in the end-stage phase of hypertrophic cardiomyopathy, in phospholamban associated dilated cardiomyopathy. And please note that there are several mechanisms leading to these abnormalities. Not only infiltration, but myocardial myocyte damage and loss of living myocytes are two causes, explaining, for example, why in AL amyloidosis, the prevalence of this finding is definitely higher, since in AL amyloidosis, there is a toxic myocarditis-like effect of the circulating precursor. Again, fibrosis and unknown intracellular mechanisms are involved. So please note that low QRS voltage is a syndrome, is not a specific disease. I would like to conclude, colleagues. In a patient with definite or probable cardiomyopathy, of course, we absolutely need to know the myocardial substrate and the genetic basis of the patient, at least. These are our two goals. And possibly, in our mind, merge these two lines of observation, the myocardial substrate and the genetic basis. Now, in my mind, there is a old but new methods that is the standard ECG, and standard ECG is probably the true multimodality, fusion imaging, very useful in the field of cardiomyopathy. Thank you for your attention.